for the glitch. Um, so like I was saying before, it's a kind of a coordinated effort. Um, because there's if you're moving patients, there's going to be more than one person involved usually, and like for us, like we're fortunate enough to have Berlin Fire go to all our lift assists, and so basically I let them kind of do all the extrication while I'm taking care of patient care. But still, we talk about it and like what's the best way of egress. So a team leader usually talks through and what's going on. And if there's a person, if they're moving from the stretcher to the bed or bed to stretcher, there's somebody that's counting. So it's always a coordinated effort. Uh, so yeah, um, like commands used are already just team leaders to stop, and everybody just stops what they're doing. Like if we're moving somebody down the stairs of Stokes, we just drop them like on the stairs, or not drop them, but put them down to reassess what we're doing. So yeah, carefully plan ahead. Usually, like we just do it so often, and we just get an idea of what's going on. That in the fire will usually um, take care of that. But like the other night, I was on a call with Errol, and there was a lot of walking we had to do, and it was lawn, and like all the way up, I was thinking which way would be the best way would be the stretcher or the stair chair, or we're gonna have to carry the patient out with the Stokes. And what do we have for availability? So I'm like always thinking like as we're going in, thinking about your egress or having somebody do that for you. Emergency moves are like if somebody's in danger, like decompensating, if there's a fire, if there's a code, or if they're unresponsive or whatever, you need to get to the patient or the airways as quickly as possible. Uh, and it's not gentle, and but and it's usually like if you try to support the head and neck as much as possible, especially if there's the mechanism of injury for cervical damage possibly being involved. Um, so some of the techniques that we use, like we'll just grab them by their pants or their shirts, where you can get some good leverage and pull the patient off, up or around, like off a bed or like out of a bathroom, or because people usually don't go unconscious like in the best of places where we can work with them. Like the other day, I had a patient who was in the living room who we had to move, and but she was laying on her side, so there's a blanket right there. Threw the blanket underneath her, rolled her on a blanket, and then was able to uh, put her in a scoop stretcher and carry her out. And then there's an arm drag and arm to arm drag, which they'll show pictures of, but generally don't do that. It's rough on people's shoulders and arms. But again, it's like an emergency case only. Uh, so this is the different types of like the grab and leg collar, like the blanket move is B. The arm drag and arm like just around their chest. Any questions on that? To remove a patient unconscious patient.
Actually, I have one question.
Shoot.
Just say you're doing the arm drag,
Yep.
because obviously I'd rather do the arm to arm drag. But if you dislocate their shoulder, is there a whole slew of new paperwork that you have to do? I mean, you've got the patient care report. I mean, you don't have to get into
You
depth. I'm just curious if there's like an accident report.
you would. I guess it would be depending on your um, agency. You might have to do a incident report or just put it in your patient care report. But again, like if you're doing it in good faith and it's an emergency move, then nobody's really going to say anything. That's and we generally don't move patients like that. That's I've never seen that. But I mean, if you have to do it, you have to do it.
If you do injure a patient, and you're doing your patient care report and your report to hand off your patient, you're going to be open and honest that that particular injury was caused.
Yes.
So there's no like waiting till you get back to the house and, back to where the ambulance goes. It's like everybody knows at
Yeah,
that point.
I would definitely report it to the receiving nurse that the injury was caused by an emergency move.
Okay.
and then put it in your report, documenting it as well.
Okay. Thank you.
Yep. Any other questions? Nope. All right. To remove an unconscious patient from a vehicle while you're alone. Well, you probably it's like a one-person job anyways, usually because there's not much room. Just make sure the patient's feet are cleared from their pedals and under the dashboard, and make sure that somebody's holding C-spine as best as you can. And like loop your arms around their armpits, kind of like they did right in the D, and just kind of drag the patient from a safe location. And again, try to maintain C-spine as best as you can. If you can have somebody behind, like putting a collar on, or just supporting the head as best as you can. Kind of like that, A and B. So urgent moves are pretty much the same thing as emergency moves. If they have altered level of consciousness, inadequate breathing, if they're shocky, and if it's like pouring out and you're out in the middle of the road, I would probably get them out of the way because it's a safety hazard for everybody. Um, yeah, so rapid extrication should be used only in emergencies. Patient can be moved within a minute or so. Like I guess that's urgent. Look at all options before using an urgent move. Like again, you're still going to be talking um, to your teammates and fire, whoever's on scene. But I mean, if you're alone and like you need to get the patient to somewhere else, then just do it. Non-urgent moves. When patients stable, like generally our general calls are stable, they're just fallen or something happens, you just need to get them to the stretcher to the hospital. Um, Team leader should plan the move. Like again, like I let fire kind of deal with the thing, but if I'm alone with another partner, we talk it out. Um, we make sure like we will go in and rearrange furniture and houses and whatever so we can get this patient out safely and without damaging. Like we don't want to bring in the stretcher or the stair chair and just start banging everything around. So we'll move furniture, whatever we need to do. Or if like we're in a nursing home, we'll move beds around and chairs there as well. Um, for direct ground lifts, like if there's somebody on the ground that you need to get up, you need to try to do the best you can without injuring your back. Make sure you have efficient help. Uh, Use a blanket if you have to, or get them on a scoop. Yeah, and like use one person on each side to make sure that you get them on their feet and they're stable. Like if you get them up, and you don't get them on your feet and then they just fall right back over because that's more paperwork. Um, Extremity lifts those who with no suspected spinal injury or supine are sitting helpful. Yeah. Patients that are like in cramped in bathrooms or whatever, just there's one at their head, and they usually have somebody like pick them up from the armpits and somebody else from the front, just so they don't slide their feet out. Again, we're talking to each other and the patient at the same time. Like we're making like, okay, we're gonna pick you up now, and this is how we're gonna do it. Da 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 da. And they'll usually say, "Oh, don't touch my shoulder. I have a bad shoulder," or something like that. So like, also transfer moves. Same thing is using this. Yeah, they're usually in a supine position or semi-Fowler's position, which we'll get into. Uh, we either just use the sheet and we'll just pick them up and move them over, or if they're like on a scoop stretcher, that's pretty nifty because you can pick them up with a scoop stretcher, move them over, and like break the stretcher, just like leave the patient there on the bed. So geriatrics is just going to be very careful about like their bones are brittle and they don't really feel as much pain as younger people do, and you got to be slow with them and patient and um, just tell them what you're doing and make sure that they understand and let them. And if they have anything that they need to tell you about, like they have a because usually if they fall, they're breaking a hip or something. So you just need to be talk about what's going on. And there's kyphosis, which you'll see a lot in older people. And I can't remember what this first picture is called, but there's a name. Hunchback. Besides hunchback, and as long as um,
Morgan, is that
bariatric.
the same? Was that the same person? Or is that
I
different?
don't think so.
Oh, all right. It just hunchback. All right.
No, that's what I'm just thought. I can't. There's a name for it, and I can't remember what
Yeah.
it is. I had to do a practical test on somebody like that and putting a kid on this, and I failed it the first time.
I bet.
I made sure he wasn't breathing the second time, and it didn't move. But yeah, if you do have to deal with that, you have to like put a lot of padding, like underneath where it's not, because that's not very comfortable to lay on. If you need to move her out, or if she's in a stair chair, that would just be really challenging. So bariatrics, we get a few of those. Um, there's a lot of obese people out there, and kids as well, with sedentary lives and not good nutrition. And they do cause a lot of back injuries, and you don't want to deal with that. So yeah, if you need people, if you have like some abuse people, just call for help as much as you can and do the best you can. But you should have special. I think Gorham has like bariatric stuff that we can use. Yeah, so stretchers, like our stretchers can lift up to 700 pounds. But if we get them in the ambulance, it would just be difficult. But just don't try to lift that on your own. So that's a special bariatric stretcher ish. So so can you see my laser pointer on the screen?
Yes.
So the
Yes.
rails for bariatric patients, that rail would not be there. They have what's called wings. Oh, this isn't even a bariatric anyways, but there's wings to support bariatrics. Generally we don't have these bigger, I guess, handles. That might be an add-on, and this is not a hydraulic either. That's really not. So this is supposed to be a bariatric stretcher, but it's really not. It just has handles, to pull and push if you need to.
So those stretchers that you're looking at now, Morgan,
Yeah, they are bariatric.
those are bariatric. They're actually the cushion is actually about maybe 8 inches to a foot wider on those,
Okay.
and
Yep.
those handles are designed for the stretcher to be fully on the ground. And the ambulances are designed with a winch inside the patient compartment.
Oh, okay, that makes more sense.
Yeah, and it pulls it up with a winch into the ambulance. The problem is now, is while the newer stretchers are, sorry, I'm rephrase that, with the new ambulances coming out, everything has to be center mount with a track, which
Yeah.
those have to have the yoke still in the front and,
Yeah.
and towards the airway seat. So with the new systems out there and the power loads, those power load systems are designed for 1,000 pounds now. With the power load systems with the power cots, and power cots with the wings are now up to 700 pounds.
Yeah,
But
that's what we have.
But that stretcher there can do up to 1,500 on the
I
ground.
see that on that, but they don't have any hydraulics.
No. So what happens is you get the patient onto the stretcher on the ground level.
Yeah.
And you use those handles. I can't use your screen, but if you have the handles coming up in front and back, and you kind of walk the patient down the hallway using those to push. And then when you get out to the ambulance, you have the ramps that come out of the back and the winch cable, and it hooks onto the back part where the airway, right there.
Yeah, I see that.
Yep, and the
Okay,
winch cable actually hooks onto that, and it pulls it up into the ambulance and locks it in place. So there's no lifting.
Okay, that makes more sense. So it is a bariatric.
Yeah, and when you mentioned the bariatric cash stuff, every county in the state of New Hampshire has one service that has a bariatric cash. So for Carroll County, it's Conway Fire. They have the bariatric setup, the winch, everything, all there in their station. And every county got through a state grant, got one per county for a department. They also have a hover mat system, the hover jack system that lifts patients off the ground up to 4 feet in the air. So there's a lot of different things that are out there for that. The problem is, like I said, the newer ambulances have the track systems now and or their power loads, and this stretcher will not work for those. So
that wouldn't fit in our ambulance.
no, it's tight. You need a full box truck for that. And it can't be.
Kevin.
Yeah, not a problem.
Any other questions?
I've actually worked with bariatric patients, and it is, you really, really have to like keep your facial expressions. It is so hard. I can't even express how hard it is to, I mean, I don't know if you guys, I know the people like you, Morgan, have worked with them, but it is probably one of the hardest populations to work with because everything is a struggle and you have to make it look like it's not.
Yep.
You have to show so much respect and care.
We say that for, it's true. It's true. So this is a regular stretcher, and with the hydraulic lifts, still no wings. But yeah, and then there's a battery right at the end. Oh, sorry, I got carried away. So this is a regular stretcher, and we talked about that. And it's easier because you only need one person to like only push a button, and there's like no lifting, so it takes a lot off the back. Um, a portable stretcher. I never used one. I'm sure they're a lot in the military or mass casualties. Um, but again, that's there for quick moving, a lot of people at once, and lightweight with tubulars, and they can just not completely on the ground. A flexible stretcher. I guess that's a lot for carryouts and rescue stuff. I use a type of flexible stretcher. It's called a Reeves, and I really like those a lot. This is a KED. I don't know if they have them in Maine still, but they kind of went on the wayside years ago when we stopped backboarding people, and it was determined that using KEDs to take people out of motor vehicles accidents was more dangerous than just taking them out. But it was, in theory, you would like have the put. Here, let me get my little trusty disc. You'd like strap this around the thoracic cavity, then this around the head, and then that would be padding, and all in theory would line up. So like, and then you'd move them out. But just like putting it on, you'd have to rock them back and forth, and it would just cause more movement than necessary. It's good for like hips and stuff if you turn them upside down. A vacuum mattress is kind of like a backboard, or they have them for like splints as well. But like as you vacuum the air up, it becomes rigid, so it molds around their arm or like the entire body, and so they can't move. But it's like pads them at the same time, so it's more comfortable for the patient. So basket stretcher again for extrication. Fire has this. We don't, but they use it for like when we have to go for an ATV or snow machine wrecks. They use them to bring them out. Or like Fish and Game will use them too to carry people out. So yeah, spinal injuries, so they're on backboards just for extrication purposes, and then they carry them out and bring them out on their little buggy. When we return to the we just left it either like, because in New Hampshire we don't backboard anymore. So like when they come out, we'll take them off the backboard. We'll just log roll them onto the stretcher or just slide it out. I don't know if they have this picture of a scoop. They don't. So a scoop stretcher, I can get one during break. These, they kind of break away down the middle, so you can kind of slide them underneath the patient, and they don't have to move. They just kind of like wiggle them underneath, and then you can pick the patient up like that, And so it doesn't, like, if there's a hip fracture or something, you don't have to move them around, and it's a lot more comfortable for them. But at the same time, the drawback, you have to have a lot of room in order to do that because you have to break them open, and kind of wing them together. Uh, Neonatal isolate. Um, I think this is kind of like things for preemies, I believe. Right, Kevin? It's gone.
Yeah, sorry about that. Yeah, so isolates are used for like premature births, things like that.
Yeah.
And they have medical air, oxygen on them. They can attach to stretchers now, which are nice. Before, when I worked for the NICU teams, they had to have like a lift in the back of the ambulance, and I used to do the ones from Maine Medical Center back in the day. And now they're all attached to power stretchers now. But it's basically almost like an incubator almost. So it keeps them nice and warm, protected. It's a glass case or a plastic case going around the infant or the neonate, and you can put your hands inside and actually do work. And again, it's a whole specialized training course you have to go through. Not any a paramedic can even take these. It's more of it's critical care, along with having neonatal critical care nurses, things like that on board. And it's a team that picks them up and brings them from one place to the next. So
And Dart has a whole team with a nurse practitioner or the doc will send it.
Maine Med would be the Barbara Bush team. And then Dartmouth is CHAD, the
Yep.
CHAD program. And Elliott Hospital also has them too in Manchester.
I didn't know that.
Yeah.
So after you use like the equipment, the stretchers and stuff, because people have cooties, there's a whole bunch of stuff that you just don't want to pass on to your other patients, that or yourselves. They need to be deconned, and there's wipes, there's spray at the hospital, and like when you wipe, you don't want to just wipe it and then wipe it dry. There's a time that needs to be wet for it to like decontaminate it. Um, so like Hep C will stay on surfaces for a long time, and you don't want to. That's something you just don't want to pass along. So patient positioning, it depends on the chief complaint. Somebody that's having trouble breathing is going to want to be upright. They're not going to want to lay down at all, or COPD or CHF. That will stop their breathing pretty quick. Patients in shock should be like supine, because you want the blood flow to get to the head and not to the extremities as much. Um, but most of the time, patients are what's called semi-Fowlers. That's like in between 90 and that's about 45 to 60 degrees. Um, yeah, unresponsive patients should be put on their sides, um, unless there's a suspected spinal injury, because you want to protect their airway. So if they vomit, it goes out of their mouth. Late stages of pregnancy. Who here? I bet somebody knows. What side should the patients be on for pregnancy when transporting? Anybody?
I know it's one side. I think it's the right.
I was gonna say it says left on here.
Does it? All right,
It's
it's left.
Yep, you want to
I
get
didn't
them
see
off
that.
the. Yeah. I didn't
Oh,
see
left
that
side
either.
right there.
Yeah, so you want to get them off the vena cava, the kid, so we can get good blood return. So usually, if you sit them like if you have to lay them down, if you lay them on the right or left side, they will have better blood return. Again, like patients nausea, vomiting, you just want to get them to their side as quickly as possible to get it out. Or I guess patient comfort. Usually, I get them to their side because I just want to get it out of their airway. Medical restraints. So we do have restraints in our ambulances. So we can do like a 4-point restraint. You never want to hog tie a patient. You never want to transport a patient or put a patient chest down, because they're able or they were likely to asphyxiate, and nobody wants that. And usually, if you do have to, if there's somebody unruly, you call for ALS if they're available and give them chemical restraints. So yeah, I think we talked about it the other day. There should be 5 people to restrain a person, one for each extremity, and then one actually doing the restraining. And well, everybody I've ever had to restrain, but oh my, we got beat bad. There was a big boys. Uh, yeah, restrain a patient in supine position, never prone or never hogtied. Actually, just call the cops and let them do their thing. Apply restraint to each extremity, make sure it's good circulation, and document why you had to do it, how you did it, what the outcome was. Question asked before removing the patient. Yeah, am I strong enough or is my patient, because you got like, if you're like stronger or weaker than your partner, like you either have to, one's gonna have to compensate for the other, or you're just gonna have to communicate very well, because you can throw each other off. Yeah, make sure there's room enough, rearrange furniture if you have to, get more personnel. Like, yeah, injured EMTs, like if you mess up your back, just trust me, it's hell. You don't want to do that. Oh, and we're done. Review. What's the first rule of lifting? Twist slowly when you lift. Yes. Keep your back in a straight position, bend at the waist to pick up something. Use your arms to do most of the lifting. B. It is B. Yep. When lifting the stretcher using the power lift, you should bend at the hips and knees, backs and arms. Bend at the waist so you keep your back straight. Place your hands and palms up on the litter handle. Place your hands, palms down on the litter's sidebars. So, see, place your palms up on the litter handle. Anything else?
I'm gonna say
Let's see.
A.
What's that?
I'm gonna say A.
A. C. That was one of those trick questions. So yeah, you never want to bend at the hips because that's going to throw your back out of alignment ish. You bend at the waist to keep your back straight. Yeah, that's a weird question. But then it throws you off of the litter handle because it asks for the power lift. But yeah, you want your palms up, in theory. Bend the knees. When lifting, always keep the back straight, never bend at the waist. It's impractical. Apply a vest type extrication device on a critically injured patient or remove him or her from a vehicle because it takes too long to correctly apply. Does not fully immobilize the spine. Cannot be used to patients who are in the car. Does not provide adequate stabilization. So there's a key word. It's critical.
A. Takes too long.
It does take too long. It does take a long time.
Ask Colin. I did it to him on a practical.
You had to do it on a practical.
Yeah. In that, yeah.
Yep.
Colin was my patient.
Yep.
Proper guidelines for correct reaching include all of the following steps. Avoid twisting your back, avoiding hyperextension of your back, keeping the back in a locked in position, reaching more than 30 inches away from your body. More than 30 inches. Avoid twisting your back.
That's A.
A. It means accept.
Oh. Lock position.
You don't want to twist your back, yeah. Keeping your back, well, you probably want to do that too. D. Yeah, you want to keep your hands close to you as you possibly can. 30 inches is a lot. An injured hand glider is trapped at the top of a large mountain and must be evacuated to the ground. Terrain is very rough and uneven. Which of the following devices would be the safest and appropriate to use? A stairs chair, B Stokes basket, C
Stokes.
scoop stretcher.
Let's go with the Stokes, baby.
Everybody all right with that? Jen, what did you think? Oh, you're muted.
I mean, I've seen a fair amount of people that come down on a long backboard as well, but I guess it could be either one.
Yeah.
I mean, Fish and Game tend to use a lot of backboards.
Yeah, they do. But usually they have them in Stokes so they can like put ropes around them and use them as brakes and stuff.
Yep.
If it's probably not very far, they. When two EMTs are lifting a patient on a long backboard. Oh my God, Jen, I'm gonna just mute you.
Oh, sorry.
Don't be sorry. When the two EMTs are lifting a patient on a long backboard, they should lift the patient from the sides of the board, make every attempt to lift with their backs, position the strongest EMT at the foot of the board, position the strongest EMT at the head of the board.
Gonna say D.
D.
See the D, right? See the C or D.
D. You want this, most of the weight's going to be at the top of the board. Which of the following techniques is considered to be an emergency move? An extremity lift, a supine transfer, firefighter's drag, or direct ground lift?
Direct ground lift. Oh no, firefighter's drag.
Yeah, probably be firefighter's drag. Did anybody have any different? Oh my God. Yeah. The extracted patient.
We've got some bad background noise.
Oh, it's probably might be me.
There you go.
Wasn't me.
To extract a patient from the basement of a building, you must transport the patient up a flight of stairs. In doing this, you must ensure that the elevated head of the backboard goes first. The backboard with the elevated foot goes first. Wait, what was it? The backboard is slightly tilted to the left to distribute weight.
A, baby. A.
A. Yeah, I would say A too. When you carry a patient upstairs or an upper incline, you must ensure the elevated head of the backboard stretcher goes first. If an injured patient needs to be moved but is not in immediate danger from fire or building collapse, you should first order the equipment you need for extrication, check the patient's airway, breathing, and circulation, remove the patient with a rapid extrication technique, determine the number of people you need to move the patient.
I always thought it would be B, but it's probably not.
Oh, it'll probably be.
I'm gonna go B. B.
It's not C. Could be D. Not A. Yeah, I'm gonna go with B too, because you always check airway, breathing, circulation.
Yeah.
Yep. The rapid extrication technique is a non-urgent move to remove a patient from a vehicle. Yep. Non-urgent move. Technique used to transfer a patient from a bed to a stretcher. Technique used to lift a patient with no suspected spinal injury onto a stretcher. Technique used to quickly remove a patient from a vehicle onto a backboard. D. I would go with D too. There. How about we come back at 6:55? We'll take a little break while we change, and then we'll get started on, I think it's medical terminology.
Tina, I don't know how you did it, but I see 2 of you on my screen. That is weird.
Yep, me too.
Dude, you got. Oh,
Oh,
okay. Am I echoing?
hey, Kevin or Morgan, while we're waiting, if one of you are online, so this next chapter, medical terminology, that's a little stressful. Like, there's a lot. Do we really need to know every single term on one of the
Yes.
last few pages?
Yeah. The best way to memorize these are write them down like 10 to 15 times.
So it's a big part of being an EMT.
Yeah.
Is everybody about ready to get started again?
Yeah. Especially when you're trying to do stuff with physicians, documentation, things like that.
Yeah. All right.
You really want to have that.
So, like, they didn't have a picture of a scoop stretcher on the slide, but we use them quite a lot. Can you still see my screen? Yeah. So this is basically what a scoop stretcher looks like. They break away on the sides, like the front and the bottom, and then the bottom part right here, if you can see my little finger pointer, you can like raise it up or down. So like if the patient's shorter or taller, and it works really good for like hips or whatever, they just can't get up. We use that a lot, and if we can like scoop them up and bring them downstairs and stuff with it too. Can you hear my kid talking or no? You can? Oh, okay.
A little bit, not too much.
See if I can. It's my first day. All right. So medical terminology. It's important to learn in healthcare so you know what like other people are saying, doctors, nurses, and coworkers. And even though you're supposed to not like talk in simple terms, it's you kind of like you have to understand that like if you throw stuff out, like you'll seem more respectable and like you know what you're doing, which is kind of half the battle most of the time. How like there's words like, and once you start learning the terminology, there's words will be used like first gastro means stomach, so you can like throw a whole bunch of things out for that, and just like the more you learn, it'll just feel the more the jargon leads to effective communication. Like the other day I had to take a transfer, and the doc who was Spanish, he said something I don't even still know what, and I was like looked at the nurse and like, what is he trying to say? And she's like, oh, the brain's not leaking or not performing right. I'm like, oh, okay. So it talks about like different parts of the body. and then like you can change the meaning of the word just by adding like vowels, or just like gastroenteritis is like a swollen irritation of the bowels. Oh my god. Hold on. Is there a lot of background noise for you guys? No? Okay, then never mind.
Not on my end.
Changing. So there's just making up the word. There's a root word, and then there could be a prefix or a suffix. And then you, in order to combine like different words, you have vowels in between, like gastro, the O, the itis, or gastroenterologist. Like ologist is a study of like the gastro area. It's important, like spelling is very important. Like you spell, like you have the best thesis in the world and you spell one word on it and it's thrown out. So even medical like reports and stuff, you should have good grammar and spelling. But just like this one right here, that dysphagia or aphasia means speaking, or aphasia with a G means swallowing, eating or swallowing. So you could say dysphagia and they would, without the S or the G,
We should have a speech
goes by
class.
different ways. And like this means means difficulty or painful. Could be dysphagia, difficulty speaking, or dysphagia, swallowing. And it shows how like anatomy of the body and stuff like that. Root words are the main part of the words, and it usually indicates a body part. So like if I say HEPA, not HEPA, would like mean the liver. So I was talking about the liver. Gastro would mean stomach or intestines. Cardio means the heart. Like cardio, if I say cardiopulmonary resuscitation, I'm talking like the heart and the lungs. I'm trying to resuscitate them, doing CPR. Prefixes, again, appear before the words, like prefix of a book. They still like to relate it to something else. The prefix of the books, it happens before the story. It's leading you into the story. So prefix of a word before. A suffix is after the word. So if I say, itis is inflammation. So time you see itis after a word, it just means inflammation of something. Like hepatitis, inflammation of the liver of some sort. Combining vowels, you need a vowel between the root word and the other words. So most cases like an O, an I, or an E. So gastroenterologist is somebody who studies inside of the belly. So summary of the rules: prefixes before the term, the suffix is at the end of the term. Use a vowel when you want to combine them. So like if you're talking about like a lung, sometimes you're talking about plural, sometimes it's singular. So if you're talking about the right lung, it's lung. If it's both lungs, it's lungs. Or if you're talking about vertebrae, it's one vertebra, and two, like more than one's vertebrae, or something like that. Or diagnosis, like I've heard that. Diagnosis or diagnoses, the apexes and the apexes. Gangliolum and ganglia, and ovium to ovia. Bronchus is like one bronch, which goes into the lung, and bronchi is all the bronchi or more than one. Prefixes indicate numbers, colors, and positions and directions. Like I said, the vena cava before when we were talking about pregnancy. So if I was talking about the inferior vena cava, that would be the lower one. If I was talking about a superior vena cava, that would be the upper vein. We'll get back to the when we talk about the human body. So there's different numbers as well. So uni means 1. I've never come across DIPL, DIPL. I don't know if Tina, you know what that means more than I, or if you've seen it, but I guess it means copy or duplicate.
It actually means 2.
Correct me if I'm wrong. What's that?
2. It means 2.
Means 2.
2.
Oh my God, I have my computer on mute as well, so I'm sorry. 2. Null, like if you ever get into data, dull means none, 0. Premi means first. Multi means more than like a bunch, and bi means more or 2 as well, like bilingual, more than one language, or bi on both sides of the body, like bilateral, both sides. Colors, if there's like certain words that mean certain colors, and then like if you can pick out like certain words, that you can figure out what it means. Cyan, like if you ever do printer ink, there's like one that is cyan, so blue. Luca is white. That one, urethra, is red. I have no idea. I should have looked that one up. CIRRH. I'll have to look that up. And the last one just means black. Maline.
It's Siro.
Cirrhosis? No.
Mm-hmm. Yeah, that's
Okay.
why it's orange red.
Orange red.
Yellow. Orange yellow.
Oh, yep. Cirrhosis of the liver. That makes a lot of sense now. See? So you'll see that with people with hepatitis. So then there's prefixes for body movement or position or location. So ab, like add, you means bring together. Ab, and then peri, you're going to see a lot in the abdomen because there's organs that have, or there's type of pains that you can talk, it'll describe it. Circum means around. Supra means above. Epi, I think it means above as well, or like rapid. And then trans means through. So it also, you can talk about pain. You can talk about pain and how it goes through the body. So, and injuries. So right, left. It's the patient's right and left, not your right and left, looking at the patient. So you got to always keep that in mind, especially when documenting. And superior, like we said before, is above. Inferior is below. Lateral, both sides. Medial. Oh my God, I can't read or spell. That just means in the middle. Proximal is closer to the body. Distal is away from the body. And superficial is like if you have a cut, that means nothing. But if you have a cut and you can see bone, or you can see in the cavity, that's a deep cut or burns. So I had to look some of these up as well. Ventral would be the palm of your hand. Oh wait, right? I did look that up. Right, Tina? Oh, no. Dorsal is back. Ventral is front.
Front.
Front. Yeah. Ventral
Palmar
is
is the palm.
Yeah. Palmar is the front palm. Ventral, like I haven't seen that word before today. And I did look it up. It means front. Dorsal is the back, like the dorsal of the fin is on the back of a fish or a dolphin. Apex means to the point. Or my wife told me it means the top, but I read it means the point, like where the apex of the heart is the bottom of the heart, where it comes to a point. So again, superior is near, like above, inferior is below. So sometimes like you'll get a report from a nurse or a doctor, like there's an inferior infarct or superior infarct or midline femur or distal tib fib fracture. And we'll get into that with the body, but distal would be like near the ankle. Again, lateral means outer, medial means inner, like towards the midline. Proximal, again, closer to the body of the trunk, and then distal is further away. Like distal pulse is furthest away, like a proximal, the carotid. Superficial, closer to the skin surface. Deep means like into the tissue. Ventral is yeah, there you go. Belly, side of the body, interior surface. Dorsal means the back. And the more you get into it, the more you'll learn. Interior, front, yeah. Again, front of the body, back, posterior. Palmar is like the palms of your hands. Plantar, like I always remember plantar from when I had plantar fasciitis, and so that's the bottom of my foot. The plantar is the sole. But then like a dorsal pulse, pedal pulse is like on your foot, on top of the foot. So yeah, apex tips of the structure. And there's like also apexes of the lungs. So then we also talk about movement, body movement with it. So like flexing is bending a joint, and then extension is moving the joint, straightening it. Abduction is like when you move towards the middle. Like if you ever get when we get to neuro, like adduction to abduction, it's important to know the difference. Bilateral means both sides. So if you like cut the body down like that, there's a left side and right side, and like bilateral means both. Unilateral means one side, or hemi does as well. So yeah, the anatomic positions, if like standing upright, your palms facing out, or lying with your face up and your palms are still facing out. Oh, that's the, yeah, we talked about that too. Prone is laying on your stomach, excuse me. I meant something else. Prone is laying on your stomach, like a sniper will lie prone. A supine is laying on your back. Fowlers or semi-fowlers is like either kind of in a sitting position, or a semi-fowler is like 45 to 60 degrees. And like I document, like when I see patients, how they were prone, like laying on their stomach or their supine. So yeah, semi-fowlers is 45, high fowlers is 90, or just sitting. Again, this is the same thing. The suffix is after the word, prefix is before the word, the root, then there's a word root, which they attach to. So like this is breaking apart this. So nephro, well, neph, what is neph? Anybody have any idea what neph means?
It's kidneys.
Kidneys, right? So nephropathy, whatever. I can't speak tonight. So disease of the kidney, pathy. O is confining like the kidney in the disease. Oh yeah, it was right there on the slide. That's the way to be observant. All right, without looking at the slide, what's this urea means? I'm gonna bring it down.
It's urine.
Yeah, it's just urine. So what would dysuria mean?
It hurts.
It hurts, troubled, urinating. Urea means condition of. So for like this one, when my wife was pregnant with her first child, she had hyperemesis. What would I mean? You talking about with that?
Morning sickness.
Right, like throughout, every day, all day. It means hyper means above average, like And EMSIS is like vomiting. Analgesic, anal means pertaining to, and gesic means pain or analgesia. Abbreviations, acronyms, and symbols. I've seen providers do it online, and I don't see it on a day-to-day basis. With people documenting, you shouldn't use acronyms or abbreviations because they could be construed for something else, and that's when errors happen. Yeah, so like when you're doing your reports, like just try not to use them. Like so one would be CC would be chief complaint, or HX would mean history, or AX would be allergies. Like you can't really, but there's one for like morphine, but which could also construed as mag sulfate. But it's just a good idea to stay away from them. Oh wow, that was pretty quick. Which of the following components of a medical term conveys its essential meaning? Prefix, suffix, word root, or combining vowels?
C.
I would say C as well. Right, because yeah, that's what the word root is. Prefixes can indicate color, conditions, body parts, or procedures.
Conditions.
Conditions, yeah, I kind of probably would didn't over. Usually come after the part like itis is last, like inflammation, and what apathy. Usually prefixes are before or for color, like cyanosis, leukemia, stuff like that. Color usually comes before, right? Understandable?
Yep.
I probably did. The plural word for the bronchus is
D.
D, right? They took the S off. The statement, the lungs are superior to the bladder, indicates that lungs are closer to the feet, the surface of the skin, head, or trunk. C, yeah. They're closer to the head. Or above the head. I mean, below the, whatever that was, in the bladder. This movement of the arm toward the midline is referred to as flexing, extension, abduction, or abduction.
A. Oh wait, hold on.
It's C, yeah. Like you're bringing it together. Adduction. Just flexing is just any, it could be any joint. And then abduction is like when they kind of go rigid like that. A body part that lies closer to the midline than compared to another is to be medial, distal, lateral, or proximal. A, right? Like if you medium of the highway is in the middle, so medial is like down the middle, like on the body. A. This is used to identify a body part that is on the belly side or interior of the surface body of the area, surface of the body, deep, superficial, dorsal, or ventral. Be superficial. Belly side. I'm gonna probably go with D. I could be wrong. Yeah, because the belly side, the ventral is like in front. And I don't know if it's going to come up or not, but there's retroperitoneal side. Retro means behind or back, like retro times. I know I saw it somewhere. You place the patient in a semi-Fowler's position for transport. That means the patient is lying on his or her back, lying his or her stomach, sitting at 45-degree angle.
C. I'll go with
What's that?
C. C.
Yeah, 45. A laceration located on the plantar surface on the foot is the sole of the foot, palm of the
A.
hand, back of A. It is the A. When using abbreviation, acronyms, or symbols, an EMT should be familiar with those used in your agency. Use only those that are medically accepted. Use them to shorten documentation. D, all the above. It's probably
A.
D.
Yeah, it is probably D, but
Yeah, you shouldn't like just make your own up like for B. Just don't. Yeah, D. Just don't. I've never really seen people use them. I've actually had one provider who's. All right, let's get. You want to get started on? Let's start on the human body. I gotta turn on the light real quick because I can't take it. Hold on. All right. Do you guys want to take a quick break, or you just want to jump into the human body? Go right into it. Okay.
I say
The
go
human
into it.
body. Okay.
let's go into it.
So I guess this is like A&P, like anatomy and physiology. Anatomy is like the structure of your body and its organs. Physiology is kind of the chemical part of it and how it interacts with each other. So again, in anatomy is the parts and physiology. All right, hold on. Go to this. There. Can you see it better? Topographic anatomy applies to the body in anatomic position. So that was what I was talking about before. I was kind of mixed up. Was when you're standing, like, let me just do it real, like straight up, and like your hands are out. So like your palms are out, and kind of your feet are almost out as well. Well, like pointing up, because that's the bottom of your feet. Then we're going to talk about the planes of the body, which kind of is, we kind of need to know, but we never really deal with it. So the corneal plane is a frontal plane, and there's a picture. So the frontal plane is like kind of, you're taking slices. Like if you're ever looking at MRI or a CT, it'd make more sense. So if you're frontal plane, you're gonna like chop little pieces up, like from the front of the body to the back of the body. A transverse is like looking, like if you ever see an ultrasound of a female, is like looking up towards the body. So like it's that way. And then the sagittal plane is like if you cut it down the middle of the body and then it sections it from the side that way. Make sense, kind of? Yes, no, maybe? Do you understand what I'm saying?
Sort of.
Yeah, makes sense. Makes sense.
Sort of. Yeah, like it's kind of hard. Like, where's my little thingy? I swear stuff open up my computer. So the frontal, like I said, right? So the transaxial is like kind of looking at the body like through it. Like if you're looking at the top of the head down or from the bottom up. The frontal is like if you're cutting it in pieces. Like if you, I'll show you like maybe in the next class, like some slides, then it'll understands it better. You just kind of have to have it in the back of your head. It's not. I'm sure it's gonna be a test question somewhere, but cells. We'll move on. Cells are like the basic building block of life, like just in humans and animals and plants and water and everything. So, and it's also the foundation of the human body. And so cells duplicate and replicate, and they build into what's called tissues. And then these tissues share a common function and become organs, and different organs make up the system, like the gastro system or neurological system. And then all those systems make up a human body, and they kind of all work together. Like my son told me the other day, like the brain is the most important part of the body because it tells the body what to do. And I'm just like thinking of this inappropriate joke of him, which I won't say, but it's like it's all kind of relative and it's all important. The skeletal systems gives us like our structure, and its protection of, and it also protects us. I wish I would have closed that down. There's like 206 bodies in the 206 bones in the body, excuse me. And there's 3 different kinds of the skeletal system. Does anybody know what the axial skeletal system is? Anybody?
Facial?
So it's facial. There's some of it that's in the facial. So yep, the skull. It's kind of like what everything is kind of goes around. It's like almost would be the body, not the body of a car, like the frame of a car or whatever. It just kind of pulls everything in. So like the skull, the facial bones, the thoracic cage, and the vertebral column. So it's basically the overall structure of our body, and it's up and down.
Minus the appendages.
Minus the appendages, yep. That's it. So then there's, I guess, joints. Whenever bones come in contact with each other, there's supporting tissue like ligaments and tendons that will connect like muscle and joints together. There's 2 types of joints, which they're going to talk about in a minute, is ball and socket, which would like be a shoulder's a ball and socket. And then a hinge joint is like an elbow or a knee. So yeah, you can do that. And your fingers and toes are hinge joints. So here's the ball and socket, like on the shoulder. And then the hinge joint. And here's yep, let me go back into axial skeletal. So this is a skull, and there's 4 bones make up the cranium, and 14 bones make up the face. The parietal bone, like the brain, is like 1 and 2. The frontal bone, the occipital bone is in the back, and that's where the foramen magnum is, where your spinal cord comes out of your skull. The maxilla is like the top of your mouth. Zygomone is like your cheek, and maxilla is on the front of your face. That's where it protects like your airway in your mouth. And then your nasal bones. I'm sure you'll see this in a quiz, your spinal cord. I bet there's gonna be questions about that somewhere. So here's your brain stem coming out of the magnum forum. The cerebrum is your brain and the cerebellum. And then your nerves come out with the spinal cord. And what is there, like 5 sections of the spinal cord? And there's 7 in the cervical area. Like there's 12 in the ribs, which you can count, and it's important to like identify in future, like when doing 12 leads and stuff like that. The lumbar is like where most injuries come from. Like when that's where people bend over, when they bend over at the waist, and it just pop. I can't think of the word right now. I should know it. And then the sacral and the coccyx is the tailbone. Like when somebody like falls on their butt and it feels like they've broken something, that's their coxal button area. So just make sure that you know that there's like 33, and then it's a good idea to know how many is in each region. The first 2 is like what move your head. There's a occipital, C1 and C2. Right, C1 and C2 are like what move your head from forward and side to side. Then the thorax area is the ribs. Like the first ribs under this one right here is the clavicle, and this is a sternal notch, which you kind of need to know about. Well, in future, if you ever keep going. So the first rib is underneath the clavicle. You really can't feel it, and then there's 2, 3, 4, 5, and then like after 5 or 6, they're considered floating because they're not attached to the sternum directly. And that's the xiphoid process. Like if you do CPR again, and I'm sure Kevin will talk about it when he does CPR, you have to make sure you don't go too low or else you'll break the xiphoid process off. And there's also like the heart, the lungs, great vessels. Like there's a lot of stuff that the thoracic cavity protects. Again, so the appendicular skeleton is like the joints, the lower extremities in the pelvis. Like, so the upper extremities is considered the arms, forearms, hands, and fingers, and the pectoral girdle to the fingertips. So like here, all the way down. And the humerus is the first long bone on the arm. Then it goes to the radial and ulna, which will come up. Again, the sternum. This is the scapula and the clavicle. Like if you ever hear of somebody breaking a clavicle, it takes a lot and it's very painful. So the scapula, humerus. So yeah, the arm is a supporting bone, and then the consists of the radius and ulna. So the radius is on your thumb side, like the radial pulses everybody takes on the thumb side, and the ulna is like on the pinky side. You should have a pulse there too. Or they have it like on the lateral side and the medial side. So yeah, again, if you're like have your palms out, it's the ulna would be on the medial side. So the fingers, they're all, or I guess phalanges. When we document, or when I've seen providers document, they document like the fingers like 1, 2, 3, 4, 5. They don't name them like that, but they're phalanges, and then metacarpals, and there's also tendons in the metacarpals and the carpals, which move your fingers. So yeah, again, the ulna is what makes you able to rotate your wrist. The pelvic girdle consists of 2 hip bones, a sacrum and a coccyx. The pelvic bone is formed of fusion of the ilium, the ischium, and the pubis. And these take a lot to break unless they're older, which people like a lot of older people will break a hip because they're so brittle and there's so much weight on them or whatever. Or they'll break the head of their femur, like in here, but it feels like a hip. So this is when I was talking about the inferior vena cava. It's bringing blood back up to the heart, and if the baby's resting on it, but we'll get back into that OB, it'll pinch it off. And this is descending aorta, one of the great vessels. Here again is the sacrum and the coccyx at the bottom of the pelvic girdle. And here, like if when we get into mechanism and injuries, the people can break the pelvic girdles, right? Or the pelvis, and it will collect a lot of blood, and it's really dangerous. Here's a pubis bone. So the femur is like the lower extremities is the femur coming out of the hips, and it's the longest and the strongest bone in the body. So if somebody breaks that, there's a lot of force that goes into it. There's like two great vessels that go into it, the greater and the lesser trochanter. Which so all the blood flow that goes down through the legs and up back through a vein. So it's important, like if you break it, you don't want them rubbing it against the vessels because they could bleed out. So the knee connects the upper leg and the lower leg, and the kneecap, the technical term for it is what, patella. When my daughter was younger, I tried to teach her how to say that. So the patella, and then the tibia is a shin bone, like it's in front, the anterior side of the leg, and the fibula is the lateral side, so the back side. An ankle is a hinge joint, which is below the tib fib. It allows you to move the foot, so it's a hinge joint with tendons. The Achilles tendon, again, a phalanges, metatarsal, callus is that's the big bone at the back of your heel. When I do patient assessments or whatever, I always check for pulses on the feet. Then I'll mark them as well. So I guess there's 7 tarsal bones, 5 metatarsal bones, and the toes are like phalanges, and they're all again hinge joints. Oh, we went backwards. Like you said earlier, it gives us our shape. It allows us movement and able to move back and forth. Bones also, they protect fragile organs and vessels. And they store calcium because sometimes we won't eat enough vitamin D or whatever, so our body will get into our calcium stores as well, so it can regulate other stuff. I can't remember what. And it also, the marrow and bones will create blood cells. Again, creates form. You should have upright posture. Protects vital organs. Oh, this is the muscle system. Yeah, and that also gives us form. And it makes our posture when we have good posture, and it creates movement. There's 3 types of muscles. I'm sure this is going to be on a test somewhere. The cardiac muscle, skeletal muscle, and the smooth muscle. You should know all 3 and what. There's 3 different distinctive. Each one is distinctive in what they do and how they react. So here are the major muscles for the male and females. The triceps, there's like, so tri means 3, and seps, they're on the back of your arm. Bi means 2, so there's like 2 on the top of your arms. Do they have the biceps? Yep. The deltoid is in the front of your chest. Gluteus maximus is the back, the buttocks. The quadriceps are your legs. Like, I don't remember if somebody lifted or not. I used to. And the traps are your shoulders and the back. And then I guess there's some in the front. And gluteus maximus is, again, is the upper butt muscle. Oh, there's 2 areas. So they're not the smooth muscle, are they? No, skeletal muscle. So skeletal muscles are, you are in control of the skeletal muscles. So like, I think, or if I want to walk, I just walk and I can control those. And moving them creates heat. And again, oh yeah, and they also protect structures underneath them. So like, if concrete or whatever, you hit something with concrete, it's going to break. But if you put something soft on top of concrete, it's not going to break as easy, or you can reinforce it too. But again, if you put something over it, and it's the same force, it's not going to break it as easy. Oh, it won't go into it. Oh, it will. So the respiratory system is very important. That's like our A1. That's what we should know, our airway system, like inside and out, and our cardiac. So it's divided into 2 areas: the upper and lower respiratory system. So when we breathe in, we're breathing in usually through our nose, unless we're an air breather or no mouth breather. We breathe in through our mouth. But what the nose does, it like kind of takes the air through the nose hairs and like gets it all like roused up and moving, and takes some of the contaminants out. Like, I don't know if you ever like take apart an air conditioner screen or whatever, and like how dusty and nasty it is. Like, you're breathing that stuff in all the time. So that takes some of it out, and it starts moistening the air. So when you get down in your lungs, it doesn't dry everything out. The oral pharynx is the mouth. So it's like, and as you can see right here, it's connected, and then just the whole thing together is called the pharynx. So the mouth is the outer part, the oral pharynx is inside, and the nasal, and then it goes down to the larynx. Oh, the epiglottitis. That's that little funny thing that, like, if you like hit it and you just start coughing or choking, but that's signals like your airway to close up so you don't start choking. And then the air goes down into the larynx, and that is where the upper and the lower break. Like, we're considered down into lower airway after the larynx, although the voice box. Again, here the apex. Remember what does apex mean? Anybody? It's
The
not on
top
board
or the
right now.
point.
Tip.
The point, right? It doesn't always have to be at the top. Like, apex means point. So like, see how they're kind of pointed? The apex is the lungs. Like, the apex of a heart is lower. So where it comes to the point. So and then it breaks apart. So we're considered the lower airway after the larynx. And then it goes down, and this right here is called the carina, and that's where it branches off, and like, it's kind of like right here where it branches off into the left or the right lung. And then that goes to the bronchioles, and then the bronchioles split into the bronchi, and then off into the alveoli. The alveoli is like, they look like little grapes, I guess. And that's where the gas exchange between oxygen and carbon dioxide take place. So, oh yeah, then there's the trachea. Sorry, and then the bronchioles and the main bronchi. So there's like main bronchi, and they look like little trees. They just keep breaking until they get really small into the alveoli. Any question about respiratory? We're going to go over respiratory over and over again, but it's like most of our calls are either respiratory or cardiac that are emergent. So like it's kind of our bread and butter. Oh, the diaphragm. We got to talk about that. That's important. That's what makes us breathe. So the bases of the lung. There's the ribs again, all 12 of them, and then like what's in between the ribs. Yeah, use my little pointer. Is the intercostal muscles again, and that will help breathe as well. We'll get into that into respiratory emergencies. So the mouth, the tongue, upper airway, the mouth, tongue, jaw, larynx. That which divides the upper and lower airways. Pharynx is the nasopharynx, oropharynx, and laryngeopharynx. And the trachea has the epiglottis. Has anybody ever heard of epiglottitis? No. Okay, so you know what the epiglottis is, right? Yeah. So what does itis mean?
An infection,
Disease or
Inflammation.
inflammation, infection.
Yep, inflammation. So epiglottitis. So you got that little floppy thing in your throat, and it's inflamed, so bad things can happen, and it usually happens in kids. Epiglottitis. So the thyroid is like right here, if you can see me, and then that's where the Adam's apple is. And then the cricoid cartilage is below that, the cricoid membrane. Again, the trachea is like just what connects the lungs to the mouth. There's two lungs held in place by the trachea, and the arteries and veins go into it with pulmonary and ligaments. What does pulmonary mean?
The lungs.
Good, lungs. And so they're divided into two lobes. Well, sure. They're divided into two lobes, an upper and a lower. Oh, yeah, there you go. So the right lung has an upper, middle, and lower lobes, and the left lung has upper and lower lobes. Does anybody know why there's only two lobes on the left side? Anybody? Take a good guess. Which side is the heart on? Yeah, we gotta make room for the heart. So within the lobes, the bronchi, the bronchioles, and alveoli, and that's where the alveoli is where the gas change really happens. So if we say bronchitis, what would that mean? I'm sure everybody's heard that word before.
So it's an inflammation of the bronchioles.
Right. So inflammation, that's when people can't breathe or they cough and they get a bad air exchange. So the pleura, which I didn't talk about, is what it covers the lungs. That was one of the words. Peri means before, around, so pleura would be also around, but it's like a membrane. So like the lungs can move inside and out without causing friction. Then that would cause irritation. So and then there's one around the just about every organ we have. The heart has a pericardial sac, excuse me. Yeah, and there's a little bit of fluid that's inside of the pleural area. Oh, there we go. There's an upper airway. There's a thyroid cartilage, and then the cricoid membrane, and the cricoid cartilage. So yeah, that's just a generic or an overview. Then the alveoli is inside main bronchi and the smaller bronchi. The diaphragm is the primary muscle for breathing. There are secondary muscles. Oh, right there. Also involved are the neck and cervical muscles, intercostal muscles, abdominal muscles, and pectoral muscles. We'll talk about that a lot in like respiratory emergencies, but that's like when they really are working to breathe, like, and you can just see like their chest trying to breathe, like and then just will sink in, their skin will sink in, or their just nose will flare, and you can just see their necks, and they're really working hard and they can't talk. So during inhalation, what happens is the diaphragm contracts and it goes down, and then so it causes negative pressure. And this is definitely going to be on a test. It's causing negative pressure because if we're not working our diaphragm at all, it's just going to be equal pressure, right? It's kind of like a vacuum or some sort. We're creating a vacuum with our diaphragm. It's sucking air in. It's creating negative pressure. I'll make one. So the pressure decreases, it creates negative pressure, and the air just comes in. Lungs will fill with air. And this is the active part of respiratory cycle. Like where the diaphragm is contracting, it's pulling it down, it's pulling the lungs down, pulling the air into the lungs. Right? Right. Say active respirations. Okay. So during exhalation is more relaxing. It's passive. That's your diaphragm's really not working. It's going to go back up, and it's causing positive pressure, and it's pushing the air out of your lungs. It takes 3 seconds to pull air in and like a second out to get a good gas exchange. So like that part is passive. Exhalation is passive. It's the diaphragm is relaxing. Right there, passive. Function, its function is to provide the body with oxygen and eliminate carbon dioxide, which is Kevin's learning like in great detail about right now. So there's a difference between ventilation and respiration. Ventilation is the mechanical portion of it. Like when we talk about we kind of use them interchangeably, like on a daily basis, but actually like when we should be talking about ventilations, like the number of ventilations a patient's taking, that is mechanical. Like how many breaths are taking is 12 breaths, 12 to 20 breaths per minute. So the respiration part is where down the chemical part where carbon dioxide gets exchanged for oxygen, and then vice versa down in the cellular level. And it's, I guess, considered interdependent functions of respiratory system. Like you can hold your breath for a certain amount, but then your body is going to force you to breathe.
Morgan, could you explain the ventilation and respiration one more time? The difference.
When you're breathing in, right, you're taking a deep breath. You're engaging your diaphragm, right? Take a deep breath with me, everybody. So you're engaging that diaphragm, right? And you're sucking air in. You're creating a negative pressure, and you're bringing air down into your lungs. Like it's going in your mouth, getting moisture. It's going through your nose. It's getting filtered. There's also like little things in your trachea. I can't remember what they're called, and I don't name them. But there's something like cilia in your trachea, so it doesn't get some of the contaminants out in your lungs, right, before they get down. And then it goes down into your trachea, and it hits your carina, and then it either goes into the left lung or right lung, and down into the bronchi, the bronchioles, and then until it keeps breaking down, it gets until the alveoli, the little grape things, where they're wrapped around with capillaries, and then they don't really talk about it here. You'll learn about it if you ever go for your A or paramedic. Homeostasis. There's more oxygen here. There's more dioxide in the bloodstream, carbon dioxide. So homeostasis says the dioxide has to move over to where it's less concentrated, and the oxygen has to move on to the hemoglobin. right? Which is kind of advanced, and then it goes off to the body, and back to the heart, and off to the body where it exchanges again, and then it's like takes about 3 seconds to breathe in, like hold your breath to get a gas exchange, and then a second to breathe it out. So that's where it's passive, and you're creating a positive pressure in your lungs because your diaphragm's relaxing, it's coming up, and then the air is getting pushed out back through your bronchioles, trachea, out of your mouth. Understandable?
I guess I just don't get how ventilation and respiration are different.
Okay. So respiration, ventilation is the act like I just talked about right now. It's like the mechanical part where the diaphragm and all that. That's the ventilation part. The respiration part is like in the alveoli where the oxygen passes over into the capillaries, the capillary beds, and the carbon dioxide passes back over to the blood, to the alveoli, and then back down in the cellular level. It goes like the oxygen goes to into the cells, and the dioxide gets back onto the red cells, and then gets back
Thank
to
you.
so it's like when we say it should be ventilations. Like if you ever get into like an event, they talk about number of ventilations more than respirations. Oh, Zach raised his hand. Yes,
Hey,
Zach.
Morgan. I was just going to jump in and just kind of maybe help her out a little bit with that. So, hey guys, this is Zach. I'm on a truck today, so I'm kind of jumping in and out of this class. But kind of a good way to kind of think of it, you have respirations also means oxygenation. So you have mechanical, which is ventilation. That's how we physically get the air into our lungs. The respiration side is the chemical exchange, how we actually oxygenate those red blood cells. So you basically have two theories here. You have a chemical reaction and a mechanical reaction. And the ventilation part is all the mechanics. That oxygenation or respiration is all the chemical exchange that happens.
Thank you, Zach.
Is it better?
Yes.
Understand it now. Okay. Any other questions, Jen? You kind of like, you're good. Okay. We're gonna go over like respiratory again and again. So like Zach was saying, the chemical respiratory systems or the physiology of it is the chemical control of breathing. The brain stems controls the breathing, monitoring of carbon dioxide. So the primary reasons for breathing is lower carbon dioxide levels. So we want to get that out. Which it's more when you get into critical care, like Kevin is, or I touched on it in paramedic school, is air, blood gas, arterial blood gas, because it's important to know. So it's called a hypoxic drive. Like if the dioxide is too high, that's when we need to start breathing more. And like it's always monitoring pH. If it's too high, we'll start breathing out faster. If it's too if pH is too low, we'll breathe out faster. If it's too high, we'll breathe slower. Like if somebody who's like hyperventilating, they're blowing off their CO2. So it just does funny things to the body. So a ventilation is a simple air movement in and out of the lungs. It's the mechanical side of it, and it requires the chest rise, fall. The tidal volume is like how much air we breathe in. Like for a normal adult, it's 500 per minute, I think, right? Minute volume. So the residual volume is the gas that remains in the lungs, but it doesn't, it's dead airspace. It doesn't really get exchanged. And it just keeps the lungs open as well. So like when we breathe out, there's always something in there to keep them open, because you don't want all those alveoli and bronchi collapsing on themselves. So the dead space is the portion that's not into alveoli. So the tidal volume and the respiration rate makes the minute volume. So the tidal volume is like, if you say 500, no, it's like so it's like 500. say for an average adult, 450 to 500, and then you breathe 12 minutes. So it's like would be a 6,000 minute volume, tidal volume. It's right. Questions on that? It's more than it just. There's a certain amount of air that you're able to breathe in. I can look during. I'll look during break and see how much it is. Like Zach, if you're still on, you can correct me if I'm wrong or if I'm not explaining it right. I'm obviously. But so regular breathing, like it's important that you have enough tidal volume so you're getting enough oxygen into your cells, which will go up to VQ mismatch, which will be right. So there were normal rate and depth. So like, oh, sorry, Tina.
Is there a way to measure tidal volume? Because I see that we're taking the respiratory rate, multiplying it by the tidal volume, and then we're getting our minute volume. Or is that just kind of a...
It's just an overview. Sorry, go ahead, Zach.
So yes, there is a way to measure tidal volume, but usually that's only on a person that has a breathing tube. You can do a bunch of formulations, you can do a bunch of math to figure out what you should expect. But in order to actually get an accurate one from the patient, really the only way is to see how much air is actually coming out of their lungs, which is with a tube down their trachea. Normal breathing, like I'm kind of catching the tail end of some of this, I apologize, but I just want to make sure. He was talking earlier about how your CO2 drive works. And just to kind of put it in a visual perspective, if you ever notice if you got a fever or you're sick, you feel like you're kind of labored for breath and you're breathing faster, that's your body's reaction to that infection. Infection usually causes your pH to get all crazy, and that's your body telling you to breathe faster to help control that pH. So your breathing is not only just for oxygenation, it's also to help breathe off pH or acids in your body. So it kind of goes again to the ventilation side and that respiration side. It's kind of multifaceted.
Yes. Understand. Any other questions about it? It's kind of it is difficult, but once you get used to it. So yeah, there is math involved, and like there's for females and males, that's like it should have a certain amount per kilogram, like of ideal body weight. I think I skipped over this. So yeah, it's characteristics of normal breathing. Is anybody know the adult normal range for an
12
adult
to 20?
respiration rate?
12 to 15.
20.
It's 12 to
12
20.
to
Yeah,
20.
it's technical. So they want a good volume with it as well. If they're not getting good volume and they're breathing at 12, then there's obviously something wrong we need to fix. There's a regular pattern involved with inhalation and exhalation. You want clear, audible breath sounds, which I'll bring in with patient assessment. Rise and fall of the chest, because sometimes they could be mismatched if there's trauma involved or if they're missing lung parts, and sometimes movement of the abdomen. And if there's too much movement of the abdomen, that can show signs something's wrong. Labored inadequate breathing patterns in adults are like labored breathing. We talked about it earlier, the muscle retractions where you can just see their necks, their bones sticking out of their necks and their ribs. Pale, cyanotic. What is cyanotic?
Bluish.
Blue.
Yeah, blue. Damp skin, diaphoresis, cool. Like they'll be in this tripodic position. You can like see it across the room. As soon as you walk in, they're like just hunched over, like trying to push their upper body up, expanding their lungs as much as possible so they can get as much air as possible. Then they're just breathing and they can't talk. The circulatory system. Oh, actually, let's take a break. It's a good segue. We'll be back at like 8:10. Good. Thumbs up. Okay, thank you. Is everybody ready to start again? All right. So I pulled up a chart for like tidal volume, what we go by. Like just to briefly go over it. This is nothing you guys need to really know. But somebody asked like, how do you know, or whatever, I think. So we go by like for females or males for ideal body weight. So it's like 4 mLs of oxygen per kilogram. So let's say there's a 6 foot, say somebody's 6 foot, their ideal body weight, this is ideal. It would be 77 kilos or 78, just to round it off. Certainly not me. I would nope. So and then we would multiply like the 77.7 by 4 or to 8, depending. So we could ultimately go up to 620 mLs for vital per breath for vital tidal volume. So then you multiply that by 12. So that'd be 7,200 minute volume, right? But then there's also dead airspace that we were talking about, that like every breath would be cutting off 100, and I looked that up. It's 150 mLs of dead airspace per volume. So again, like in order to adjust the pH or like make sure we're oxygenating, we can either increase the tidal volume, the respiration rate, or how much oxygen we're delivering to the patient. But again, that's like furthering your career, something like Kevin's going to school for. But it is quite a lot of oxygen that we can give. But it's just like that's something that you don't need to know for any testing purposes. Yeah, let me put my screen camera back on. Any questions about that? Anything else you want to know? So like that's the way like as medics or respiratory therapists, doctors, critical care people can adjust something like that. So we're going to jump into the circulatory system and the anatomy of that. It's kind of like it's a pump system for firefighter guys. It's a closed connection. It's the heart is the pump, and there's like considered 2 pumps. The arteries, arterioles, which break off from the arteries. The capillaries, which break off from the arterioles, are like little tiny, where the gas exchange between the cells and the blood occurs. Then you have vanuoles, which are, and then go into veins. So there's 2 circuits: the systemic, or the circulation of the body, and then there's the pulmonary circuit into the lungs circulation. So again, there's like 2 ways. There's 2 pumps. So if the body, let's start with the body, like going out, like from in the body, the blood is in the body, it's already, and it needs to work its way back to the heart. It's either gonna, if it's in the lower part of the body, it's gonna come through the inferior vena cava, or if it's in the upper part of the body, which 75% of the blood flow from the heart goes into the brain, I think. Oh no, a lot of it does, but 75% goes through the carotid arteries. That goes up to the brain. Anyways, it goes to the right atrium, because we're like looking at the patients in the direction of the patient. So it goes in the right atrium for the first chamber. And then it pumps again, and it goes down to the right ventricle. And then it goes into the pulmonary arteries. And these are, again, deoxygenated. And this will probably be on the test, is the only veins, deoxygenated blood that goes through our arteries are the pulmonary arteries, which it goes into the capillaries of the lungs, where it gets the exchange takes place, the gas exchange. And it comes back, because it's going through the heart, it's the pulmonary veins. And these are oxygenated. And there's going to go into the left ventricle, left atrium, and then go down into the left ventricle, and then it's going to get pumped out through the aorta. And then there's the ascending aorta and the descending aorta. The ascending goes up into the head or the neck area, and the descending goes down into the trunk and into the lower extremities. Right. So any questions? No. Okay, which is the vessel that brings the deoxygenated blood from the heart to the lungs? The
Superior?
deoxygenated. Nope, the deoxygenated blood from the heart to the lungs.
Oh, to the lungs.
Right, this one right here, the blue.
Pulmonary.
Pulmonary.
Veins.
Pulmonary.
No, pulmonary arteries.
Anytime it's leaving the heart, it's an artery.
Yeah.
So it's the deoxygenated blood leaving the heart, going to the lungs. So it's an artery. And then when it comes back, what is it called?
Pulmonary vein.
Pulmonary vein, right. Where does it dump into?
Left atrium?
Yes, the left atrium. Then it goes down to the left ventricle. And that's where like hypertrophy starts happening, because that's the workhorse of the heart right there.
Hey, Morgan, I think you cut out when you were talking about how the pulmonary artery and the pulmonary veins are different than any other veins in the body as far as their oxygen capacity. Do you mind going over that again?
No, absolutely. So again, so when it comes in through the inferior or superior vena cava, these two great vessels right there, jumps into the right atrium, and then it goes down to the right ventricles, and the deoxygenated blood goes out to the pulmonary artery, because it's leaving the heart, it's an artery, and the blood is still deoxygenated, and it's going to the lungs, where that gas exchange is going to take place. It's going to dump the carbon dioxide and pick up the oxygen, and then the pulmonary vein, because the vein brings it back to the heart, dumps it into the left atrium, because the top of the hearts or atrium's the bottom of ventricles. And then so the dumps that into the left ventricle and then back out again and through the aorta. And that, if you ever seen an aorta, it's massive. Did everybody get that time? Better, Zach?
Yeah, and I just know the registry likes to harp on that
Yeah, they do.
Pulmonary artery is the only artery in the whole body that carries not oxygen-rich blood, and the pulmonary vein is the only vein in the body that brings oxygen-rich blood. So any other place in the body, your artery is always going to be your oxygen-rich blood. Your vein is going to be your oxygen-depleted blood, but except the ones at the heart. And they love to try to trick you with that during your test. So just make sure you got a good grasp of that.
Any questions about that? No, clear as mud. So the heart is an hollow muscular organ, obviously, because it's pumping liquid through it. It works as two paired pumps. There's with 4 chambers. And again, we talked about it at the beginning, and I think they're going to get into it, and we'll talk about it definitely. It's made of special cardiac muscle, which has like 3 unique properties to it, which we'll talk about. This is again divided into the upper is called the atrium, like A, the upper, V, the ventricles are the lower part of the hearts and chambers, and then there's again the right and then the left, atrium and ventricle. Circulation, the heart receives the blood from the aorta. So the heart receives the blood from, oh yes, it does, excuse me. The heart receives the blood from the coronary arteries, which, okay, so if your heart is, I guess, about the size of a fist, right? And then your ventricles kind of wrap around your the coronary, yeah, wrap around your heart, because your heart is like a huge muscle as well, so it needs oxygen and nutrients. And that's what that means. It's not talking about coming in from the circulatory system. The heart receives blood from the aorta, because we'll just go with that. The coronary arteries come beat off of the aorta. The right side receives the deoxygenated blood from the veins. It goes down to the ventricles. The left side receives the oxygenated blood from the lungs. Right? We went over that. Understandable? Right.
I can clarify that a little bit too, if you want me to, Morgan.
What's that?
The heart, how it kind of receives its blood.
If you want to.
Yeah, so guys, you got your heart and it squeezes, right? And every time it squeezes, it's going to push all of that blood out. And then when it relaxes, it creates a vacuum almost. And what it does is, I'm sure you'll eventually learn, you have a systolic and a diastolic pressure. The systolic is when the heart is pushing or squeezing. The systolic or diastolic is when it's relaxed. During that diastolic stage, the heart's relaxed. It almost kind of sucks blood from that aorta back into the heart. And that's what basically keeps the heart full of blood, fresh blood, and keeps it oxygenated. Now, to go further on, when you have a heart attack, it's when those vessels get clogged and your heart can no longer get that oxygen-rich blood. And that's what causes a heart attack. So it a good kind of lead in for the future, but just know the heart gets its oxygen and its blood while it's relaxed.
Oh.
Zach, is it almost like that negative pressure that, like, when your diaphragm is dropping and you're breathing, and that's when you're getting the air into your lungs? Like, is it almost that same?
So here's
Because it relaxes and it's pulling it in.
In theory, yes. There's some mechanical parts to that as well, but in theory, yes. Because you think about it, if you're squeezing it really hard, it's not able to really pump blood back onto the muscle that's squeezing. So that muscle has to be relaxed. That muscle has to be relaxed. That blood is drained back.
Okay.
So I've had this video I found earlier. So this is the heart, and you can see all these coronary arteries that are going through the heart, and it's kind of pumping. And usually there's a twisting motion, and that's the aortic, and that's a tricuspid valve. Like tri means three, but you don't need to know that part. And I don't think there's any really more of that. That's interesting. Let's get rid of that. So yeah, but they just have that their heart receives this blood from the aorta. It's kind of confusing the way they put it. Where do we go? Backwards. So we talked about this again. The blood comes in from the superior and the inferior vena cava into the right atrium, goes to the right ventricle. The ventricle's on the bottom, and then it goes out to the pulmonary arteries. So the left and the right pulmonary arteries, and then it comes back through the pulmonary veins into the right atrium, and then goes out down to the, left atrium, goes down to the left ventricle, then goes out towards the aorta. That's the ascending, then descending's down here, and then these go up into the head and neck and the torso area. And so, yeah, I'm not sure who said it, but the positive pressure is on the artery side, and the negative, it just like draws up, kind of like a pump. There's a negative, has to be a negative as well, like kind of pulls the blood in from the legs and stuff. That's why it's important to keep be cognizant of how pregnant people are placed. Maybe. So what's the normal, I don't know if anybody saw it, normal heart rate for an adult? Anybody?
60 to
So-
80.
Yeah,
It's close. You have the bottom number.
I think it's 100. 60
Yeah,
to
it's
100.
100.
Oh,
Right. So when
okay.
we do CPR, we want to get 100 beats per minute. So it's like 60 to 100. Stroke volume, and you're not going to need to know these amounts, but it's good to know the formula. And you're probably going to see a test question on this as well. Stroke volume is the amount of blood that is the heart beats out. And they're going to know this. Need to know this formula is cardiac output is the amount of blood that is pumped out for a minute. Like you're not going to need to know how much, but it's heart rate times the stroke volume equals the cardiac output, which is important if you're dealing with cardiac patients, because like if there's heart damage, their cardiac output is going to be lesser. So the cardiac muscle is interesting in itself, and it's unique because there's three. Let's see who read it. What are the three? There's three things that make it unique for cardiac muscle. Does anybody know what they are? No. So autonomy, the electrical current, and its contractions. So it has its own electrical system. Like the heart, the brain kind of like controls the heart, but it does it on its own as well. It has its own electrical system. It's what's called the atrium, which kind of gets makes it fire off all on its own. And then it's able to like contract and pump, which other muscles can't do that. And then I don't know what I'm talking about. Yeah, so it's electrical and it's pumping and it's autonomy. It works on its own, but the brain can release like adrenaline to like pump it up, or beta to slow it down. But that's coming up. So arteries carry the blood from the heart to the body tissues. Aorta branches into the coronary arteries, which go like into the heart. The carotid arteries are into the neck. Hepatic, where's the HIPAA mean? Liver.
The liver.
Yep. So it goes into the liver, like the liver does a lot of filtering. The renal arteries, so the kidneys, and then mesenteric arteries. The pulmonary arteries carries oxygen poor blood to the lungs, where the gas exchange takes place. The arteries branch into arterioles, so it's like arteries, and then it goes into smaller arterioles, and then that goes down to the capillaries, where goes into the capillary beds, and the gas exchange takes place. So pulses, like you can feel a heart rate from pulses, like they're all over your body. So the wrist, so the carotid pulse, the radial pulse, ulna, there's like a bunch down on your feet. There's the femoral artery, like on your right there, on your, like when we're doing CPR or whatever, I always like reach, because it's one of the central ones is a femoral. So if I always feel for that to know if we're doing good CPR, and if once we're done CPR, like if we're doing a pause, I can see if there's a pulse or not. So it's like basically like pushing an artery or arterial against the bone. And that's where you can feel the. So these are all the different arteries and arterioles. I don't think you really need to know you don't need to know all of these, but it's good to know them, like especially if you're taking a report or giving a report. So the brachial, like when we do kids, their brachial is like on right there on the, well, I don't know if you can see me, like on the bicep area, you push towards the humerus. So that like you can see the aorta like coming off the top of the heart, and see how big it is until like the femorals. And like you cut one of those, and a lot of blood is lost very quickly. So the capillaries connect the arterioles to the venules, and they find end divisions of the arterial system, and they allow contact between blood and cells. You don't want free blood flowing out. Bad things happen. The body actually doesn't like the blood directly. The veins return the blood, depleted blood, back to the heart. The superior vena cava carries blood returning from the head and neck, shoulders. The inferior vena carries the blood from the abdomen, pelvis, and lower extremities, and they join at the right atrium. The spleen is located on the rib cage, and it filters blood as well. And like if football's notorious for like splenic injuries, spleen injuries, and snow machines or four-wheelers, we're getting a lot of those with spleen injuries, and they have to go to Dartmouth for surgery, or just they watch them a lot now. But a lot of blood can be lost through spleens. Blood is composed like plasma. This is you're going to need to know. Plasma, which consists most of it, it's that clear yellowish stuff. And then the red blood cells, they're erythrocytes. Erythro means red, and cytes means cells, so red blood cells. And then leuco means white, and cytes means white cell. And then also platelets for clotting. Blood pressure. So when we're taking blood pressure, which it is important for the overall function of the body, and like including the head, for the cerebral spinal fluid. But the pressure is what is exerted against the walls of the arteries. So the systolic is when we start taking blood pressures, the systolic is like the pressure that's being pushed out from the heart. The diastolic is the pressure that's being pushed against the heart itself and as it's relaxing. So the blood pressure readings, the systolic is the high point, like the 120 is a high. That's the part of the ventricle pushing. And diastolic is like the 80, like 120 over 80 would be like when the heart is at rest. So automatically adjust and controlled. It's perfusion. We want to keep a certain type of blood pressure, so that like all the organs are being perfused adequately with nutrients and oxygenated blood. So if they don't, like the cells can start dying. Like it takes 4 minutes for brain cells to start dying, or cardiac cells as well. And the body just like it's part of the smooth cell system that just does it automatically with hormones. That's the word I was looking for before. Hormones the body releases. The system can address a small blood loss. Like there's 5 liters of fluid or 8 quarts in the body. So like we can compensate for a certain amount, but then after that, we just end up in decompensation, and then we can't come back. I mean, arterial pressure can detect shock. So yeah, like we'll talk about that when we do patient assessment. So the leukocytes and monophils, and there's a whole bunch of other cells in the blood that like that vital infection, and they transport oxygen from the lungs to the cells, and then transport carbon dioxide from the cells back up to the airway, the lungs, to get rid of it. Like Zach was talking about earlier, we control pH by our respiration rate. because dioxide will mess with that, and it's transporting waste and nutrients as well from like the and it goes through the kidneys as well, and it transports like waste to the bowels and the kidneys, and it's coagulations for platelets. There's a whole cascade system. Any questions about circulatory or blood? No. So the nervous system's what controls your body. And sympathetic nervous system is responsible for the fight or flight response. And it sends commands to the adrenal system. Like if somebody scares you, like your heart starts pounding and you're just like get nerved up. It sends like a whole hormone into your body from the adrenal glands, and then like epinephrine or norepinephrine is secreted to the blood vessels. It's like for our caveman days when we fought, we'd like get super strength or like could see better. So the blood vessels have alpha-anergic receptors, and the heart and lungs have beta-anergic receptors. So that what that means, like the blood. So especially when you give medications, like you're trying to manipulate the body what you want it to do. So like we'll give epinephrine for, which is adrenaline. We want to constrict the vessels and get the heart beating. We'll give albuterol for a beta effect, which will open up the bronchioles to get more oxygen in and out. The baroreceptors are in the blood vessels. That's what controls the blood pressure. So like if you want more blood pressure to the head or throughout the body, it'll clamp down. The sympathetic and parasympathetic nervous system balance each other out. It's like the homeostasis I spoke of earlier. You don't always want to be at that ready state. Like you want your body to chill out as well. So like when you're eating like a great meal, like your heart rate will slow down, your blood vessels will not constrict, the other word. Jesus, I can't think tonight. But so it just will filter more blood out. So it's like always important, like that stress reliever. And your digestive system will kick up more when you're like in that state. It works better. Like if you're in a go state, your digestive system like shuts down in a way, it slows down. So this nervous system's broken up into two main parts: the central nervous system and the peripheral nervous system. Does anybody know what the two different ones are? Like a central nervous system, what's that? What does that consist of?
Is that the brain and cord, the spinal cord?
Yes. Good. Yes, the central nervous system is the brain. It consists of the brain and the spinal cord. And the peripheral nervous system.
Be like your extremities.
Well, yeah, the like what
The
shoots
rest of
off.
it.
The rest of it.
The rest of it.
The nerves. So there's the brain, the cerebrum, and the cerebellum. Like the brainstem, that's the man cave part of the brain. That's what kind of does our function, like if we lost the top part of our head, like right there, we could still be able to breathe and have a heartbeat just because it wouldn't affect the brainstem, but we would not have any thought process. So this is where all our thought and emotion is, up in the cerebrum. But which is the first part of the central nervous system. Cerebral spinal fluid. There's ventricles in the heart. The brain that also like create the cerebral spinal fluid and then keep it circulating around the head. And again, and like the circulation of the head, oxygen is supplied by the carotid arteries, and deoxygenated is taken away with the jugular veins. And like the brain does not like blood at all. So here's the spinal cord, and then the nerve endings. So the peripheral nervous system's into two main portions: the somatic nervous system and the automatic nervous system. What does anybody know what the difference of those two are? No. So the somatic is involuntary, like what happens while you cannot control it, like your digestive system, your circulatory system, right? Oh yes, excuse me, I messed that up. The somatic is the voluntary muscles, so the skeletal muscles that you can talk, like moving my arms or walking or whatever. Like you think about it, but you really don't have to think about it. The autonomic is the stuff that you really can't control. The sympathetic is a fight or flight, where your body's like ready to either fight, whatever, or get out of dodge. And the parasympathetic system is what slows it down. Like you just want to like relax and take it easy. There are two types of nerves within the peripheral nervous system. The sensory nerves carry the information from the body to the CNS, and then the motor nerves carry the information from the CNS to the muscles. Makes sense. So there's two types of nerves. Sensory nerves, so like on your fingertips, those would be sensory. And the motor nerves are like in your muscles and stuff. Any questions about nervous system and nerve? No. So the interior, oh my God, gementary system, the skin. It is an organ, and it's the largest organ on the human body. That will be a test question. That's a Jeopardy question, I'm sure. But everybody forgets about the skin, and it's very important to the body. So there's like 3 layers. The epidermis. Epi means what?
Close to the surface.
Closest to the surface. So like the skin, the top of the skin is the epidermis. The dermis is below that, and the subcutaneous tissues what's below, like underneath that. So like the fatty stuff, tissue, like where the hair comes from, all that. So here's the epidermis, like, and these are the capillaries, the muscles, hair follicles in the dermis, and then the fatty tissue. Like when we give medication, sometimes we need to be in certain areas, like subcutaneous or in the dermis. Or if we give IM injections, we have to like be down into the muscle. What important things does the skin do for humans, or for anybody, I guess? Why is it important to have skin?
Doesn't it help
Protect
regulate
from
the body
disease.
temperature?
Right. Regulates body
First
temperature.
line of defense against infection.
Yep, keeps bad things out. Anything else? How does it regulate body heat?
Sweat.
Perspiration.
Through the pores.
Respiration.
Yep. And then like we'll get goosebumps, and then like that creates energy, which will create heat as well. So I read a book once, and they talked about like one of the punishments somebody got was like being skinned alive, which it was back in the Middle Ages, and they did that sort of thing. And they're like, yes, and then this person will die from hypothermia. I'm like, that is morbid. But which is true. It's part of like it won't kill somebody, but it'll hurt, and that's the way they'll go. So yeah, it regulates body temperature, and it'll lose really quick. Like taking a skin off a potato, like if you leave the skin of a potato on for a long time, but as soon as you break it open, it just cools down. So it's the single largest organ in the body, protects the body from the environment, like all the bad stuff, bacteria, which is trying to get in, regulates body temperature, and transmits information from the environment to the brain as well. Like if we touch a stove, we want to make sure we're not leaving the stove, like our hand on the stove, or anything else that can hurt. So the digestive system. Any questions about the skin? So gastrointestinal system. Gastro means digestive system or stomach. So what we consume food and turn the food into energy. It contains major organs of digestion and secretions, organized into 4 quadrants. So the abdomen, there's 4 quadrants. I don't know if there's a picture. There is. So it's kind of muddled in here. You take like your umbilicus, your belly button, and you run it like down from your xiphoid process, or I mean your sternum down to your pubis, like that area would be cut into like 2 spheres, and then you cut along like your waist area. So to make the quadrants, and like depending, like people have belly pain or whatever, you're gonna figure out what's going on with them from that where it is. So there's a like when we're looking at the patients, so this would be the right upper quadrant, the left upper quadrant, the left lower quadrant, and the right lower quadrant and the left lower quadrant. And you need to know like what is where and when these quadrants, and it'll definitely be on the tests. So the liver is on the right side, the stomach would be on the left, the gallbladder's like that green sac right there. So it'd be on the left, and the spleen, on the right. It'd be on the right, and then so spleen would be, not the spleen, that appendix would be on the right as well, and the spleen would be on the left, upper quadrant. So if somebody has left upper quadrant pain, and then they have a traumatic injury, you just think spleen. Like, and a lot of times if there's abdominal pain, it'll be referred somewhere else. So the digestive system consists of the mouth, leaves like the oral pharyngeal areas, salivary glands, oropharynx, esophagus, stomach, and pancreas. Does it go into the liver, which then the liver creates bile, and bile ducts, which gets into the gallbladder. The small intestines, large intestines, appendix, and then finally the rectum. So basically what happens is like you chew food, you were breaking it down with your teeth or whatever, and you're starting this saliva is kind of acidic a little bit, so you're starting to break it down already in your mouth, and then it creates lubrication to get down into your stomach, and then that's where it breaks down even further and it churns it up and it has like hydrochloric acid and stuff for liver and enzymes to break it down even further, and then it dumps it into the small intestines. Oh my god, it's been so long. It goes into your small intestines, and then it dumps into your large intestines, where like it basically pulls the water and the nutrients out, and then you go to the bathroom and it excretes out of your rectum. And it takes like all the nutrients, like just not basic sugars, fatty acid, and amino acids, and then vitamins, and it's further processed by the liver, and then it gets pulled out. The nutrients get pulled out in the blood in the intestines area. Any questions on the digestive? You just kind of need to know like the areas, what is where in the abdomen area. The lymphatic system is kind of like the creating hormones and stuff like that, which what regulates the body overall. So it supports the circulatory system and the immune system with adrenal or lack thereof. Lymph is a thin straw-colored fluid that carries oxygen and nutrients to cells and waste products away. It helps rid the body of toxins and other harmful materials. So the endocrine systems, I guess I messed that up. Okay, yeah, the lymphatic system is it's a filter system, like the spleen and the HEPA and the kidneys, the liver and the kidneys. That's what that is. Excuse me. Endocrine system is the hormone producing. It creates complex messages and control system. It's what starts puberty, what makes you breathe, stuff like that. So epinephrine and norepinephrine is made in the adrenal glands, and insulin's made in the pancreas. And glucagon's made in the pancreas too, but the isles. So the hypothalamus, the pineal, like all these are the different glands. The thyroid, like if somebody will have a hyperthyroid or hypothyroid, and they usually have to take medication for it. Here's the kidneys, but the adrenal glands are on top of the kidneys. The pancreas, which creates glucagon as well as insulin. That's at the alpha, beta, or like the sympathetic and parasympathetic. The men have testes, which create testosterone. The ovaries for women, which create estrogen and something else. Any questions about the endocrine? No. The urinary system, it controls fluid balance and filters and eliminates waste. And it's also controls pH in the kidneys. So the blood, there's obviously arteries and veins that come through the kidneys, and it filters it out, and then the urine gets collected into the bladder. And then once the bladder is full or whatever, it's like, oh, I have to go to the bathroom, and then it gets discharged. And it really regulates the pH, or water level. Like if you're not dehydrated, you just don't urinate as much. And if you do, it's like either like darker or orange or brown even. So it has more concentration of nasty stuff. And it regulates pH as well, because if it dilutes it, or it'll add stuff to the blood to lower the pH, or if you're like drinking a lot of fluid. The genital area controls the reproductive process. Males consist of the testicles, epidermis, the fascia deferentia, which I looked it up. The prostate glands, the seminal vesicles, and the penis. So the testicles, which creates the sperm, the urethra, which is quite long. So like urine comes out of there, sperm can come out of there. So the prostate gland. So the testes are on the outside of the body to regulate heat more as well. The pubic bone's right there, and the scrotum is what holds the testicles in. For the female systems, genital system has the ovaries, fallopian tubes, uterus, cervix, and vagina. So the cervix, which we'll cover a lot in OB. So there's the ovaries and the fallopian tubes. Like the ovaries catch the eggs, and in theory, is supposed to go down into the uterus, where they're either what's the word I'm looking for? Become babies or not babies. And then if they're not
fertilized.
Thank you. Fertilized. I know. I'm so fertilized. Become fertilized, and if they do, they attach to the uterus. And if not, then they get expelled. So here's a side view of the area. So here's the vagina, the cervix, uterus, and there's the fallopian tubes or the eggs up there. Oh, vagina, right? Moving on. Life support chain. Any question about the reproductive organs, urinal? No. So life support chain, all cells or body require oxygen, nutrients, and like removal of the waste. The circulatory systems carries the supplies and the waste, like they carry the nutrients and the oxygen, and then they take it away. The carbon, other stuff, bile. If interference occurs, cells become damaged or die. Which is called necrotizing. Cells use oxygen to turn nutrients into chemical energy through metabolism. Yes, and that's a whole another lecture. So if there is oxygen that available to the cells, it's an aerobic metabolism. So like when they turn the nutrients into energy, it creates waste. If it can't get rid of the waste, that's when they become acidic, lactic acid. So yeah, cells switch to anaerobic metabolism, like they want to live. So there's a backup plan, but if they can't get rid of their waste or this carbon dioxide, bad stuff happens. Movement of oxygen, waste, and nutrients occurs by diffusion. Again, like I touched on it a little bit. It's like the equalizing. It's late. I can't think anymore. pH is critical to diffuse. So, like if our pH is out of balance, our cells won't be able to get rid of their waste, and then it creates a shift in the oxygen saturation. The body expands a large amount of energy to maintain a more normal pH. Like two of the ways are metabolic and respiratory, which you don't need to know about, but like we can increase or decrease our breathing rate to get rid of carbon dioxide, or we can create fluid or get rid of it with our kidneys. Our kidneys does a lot of for maintaining pH. The study of functional, so physiology is the study of functional changes that occur when the body reacts to disease. Respiratory compromise and ability to move gas ineffectually. So hypoxia occurs. Does anybody know what hypoxia means? Has anybody heard that word before?
Yeah, but I can't remember what it means.
So like,
Does that mean you're not getting rid of the CO2 in your body?
That too. It kind of goes with the other one. It means below normal, like hypo, no oxygen, low oxygen levels. So hypoxia. Hypercarbia, like above average or above normal carbon dioxide levels. So like we're just gonna start having more carbon dioxide in our bodies than we can get rid of, and then oxygen. So factors that impair ventilation is a blocked airway. Like our diaphragm is like if we have a cervical injuries and our diaphragm is not working appropriately, or intercostal muscles aren't working as the way they should. We have asthma or bronchitis or COPD. Like there's a whole list of things that could mess with breathing. So this is the ventilation part. Remember we were talking about that, and I think Zach is his name. Gave a good talk about it. So this is the mechanical part of it. So the respiration factors, like the chemical part, is a change to atmosphere, because the higher up we get, the less oxygen there is. So then it also causes issues, like if we go diving and we come up too fast, there's an issue with gas in our bodies. So impaired movement of gas across the membrane. If there's not enough oxygen, we won't be able to get it in our cells. So this is what we call a VQ mismatch. V, it means ventilation, and Q, I don't know what it means, why it says a Q. I don't know if Zach or Kevin knows. But so what basically they're talking about, if there needs to be a ratio of like oxygen to blood, like you need a good oxygen supply or ventilation supply for the blood supply. So if we have too much or not enough blood to supply the oxygen, it's pointless to have the oxygen because we're not going to be able to get it to where it needs to go. So like that's why shock is so important to fix as soon as you can. And if there's not enough oxygen for the blood is going to be circulating like carbon dioxide and bad stuff, and it won't be oxygenating like the brain or other vital organs. So again, like the VQ mismatch is like blood and oxygen levels or respirations. Any questions on that? No.
So V stands for ventilation, Q stands for perfusion, and why they picked Q to designate that's a great medical mystery, but Q stands for perfusion.
Yep. So any questions on that? No. So effects on the respiratory compromise of the body, oxygen levels flops, carbon dioxide levels rise, and again that affects the pH and as well as cellular level. It causes acid. Respiratory rate increases, so we're gonna try to blow off some of that carbon dioxide. Blood becomes more acidic. Like the brain sends commands to the body to breathe, so we're gonna start breathing more quickly. And cells move from aerobic to anaerobic metabolism. So that's where lactic acid comes in. Like it's gnarly on cells. Shock occurs when the organs don't have and tissues don't have received enough oxygen, and so they become hypoxic and then start dying. The categorizes there's different types of shock depending on what level there is in the cause. Effects of shock on body. The levels oxygen supplies fall. Cells engage anaerobic, so they're basically like on their last leg. Severe metabolic acidosis ensues. Baroreceptors initiate release of epinephrine and norepinephrine, which just makes it worse because your body's just trying to circulate it to compensate. The heart rate increases, and the interstitial fluids move into the capillaries. So like you have fluid outside of your tissues as well. It's just kind of, and so it's just going to start moving into your capillaries, and it's just going to cause more problems. Impairment of cellular metabolism. So the inability to use oxygen and glucose at the cellular level, because like another problem for the V and the V, I mean the Q and the QR dispatch ratio is if like insulin, they don't have that energy to unlock them to create the energy from the oxygen. So cells create energy through anaerobic metabolism can result in metabolic acidosis. The brain cells cannot use alternative fuels, so it's like glucose and oxygen. If they can't get that, they start dying, and then cellular injury becomes irreversible, like because of lactic acid buildup or pH. Like kidneys are irreversible if they get damaged, and brain cells are definitely damaged. So to I guess review, and I don't know if I talked about this. So which of the following are found in the retroperitoneal space? So retro, remember I said I touched on it. Retro
back.
means right, the back. So like back in time, like the good old retro times, the back, retro. Peritoneal. Does anybody remember what the retro we're talking? So that would be in the abdomen area, like this area down, but in the back. So what would be in the back of the abdomen area, but on the back side? I know I didn't really talk about it. It might be in your books. So if you read, it would be C. Kidneys. So the liver is up front, like the stomach's on the left side, the spleen, whatever, which way. But the kidneys are in the back. Like, if somebody has kidney pain, will like have pain back here on their flanks. C's. So yeah, let's go back up. The liver lies immediately below the. I mean, the liver takes up all this area below your diaphragm. It's huge. The spleen lies underneath the rib cage on the left upper quadrant, so that'd be right here. The kidneys on the retroperitoneal, and the stomach lies on the left upper quadrant as well. The what is that word? Cartilunginous tip of the sternum is called a costal arch, mandiburum, angle of Louis, or xiphoid process. We get D, xiphoid process. It is D, the xiphoid process. Like, you can feel it on yourself, right? If you like run your finger down, like as it drops off, that's a xiphoid process. The angle of Louis is like right here. Yeah, the ribs, the arch is right there. A person with bilateral femur fractures has a bad day. Fractured one of his or her femurs, fractured both of his or her femurs, one femur fractured in two places, fractured a lateral aspect of the femur. B. Yes. Both bilateral means both sides. So both femur fractures. The most prominent landmark on the anterior surface of the neck is the mastoid process, the cricoid cartilage, the thyroid cartilage, or the cricoid membrane. Anybody? B? Oh, I'm going with B. Just because, oh, it's C. I should know that. Oh my God. Yep, the thyroid cartilage is referred to as the Adam's apple right there. Below is a cricoid cartilage located inferior below the thyroid cartilage. So Adam's apple, I should know this. And then just below it, the cricoid. The insulin is produced in A, the liver, B, pancreas, C, thyroid gland, or D, adrenal glands. B, it is pancreas. Blank connects muscles to bones, ligaments, cartilage, tendons, or joints. Ooh, I don't think. A, ligaments. C. Tendons connect muscle to bone, ligaments connect bone to bone. Cartilage is smooth connective tissue covering the ends of the bones. Joints consist of the ends of the bones surrounding the connecting supporting tissues. So ligaments connect bone to bone, cartilage or tendons. Correct, tendons. I think ligaments connect muscle to bones too. The normal resting heart rate for an adult is A, 50 to 70, 60 to 100, 80, C to 180 to 110, or 10 to 110 to 120. It is B. The normal resting heart rate for, yeah, I didn't know that. Oh, told you. The left atrium of the heart receives blank blood from the blank. The left atrium receives oxygenated blood from the lungs. The left atrium deoxygenated blood from the body. The left atrium of the heart receives oxygenated blood from the body. What do we have? B. So the left atrium, so everything on the right side receives the deoxygenated blood already. So the left atrium, so it'd go from the right atrium to the right ventricle out to the blood. So that's the deoxygenated blood. So we can get rid of B and D. And then so the blood goes from the pulmonary artery to the, from the heart's pulmonary artery to the lungs through the pulmonary vein with oxygenated blood to the left atrium from the lungs. So it would be A. Right? Get it? You got to break questions down like that a lot, especially in National Registry. Like, so the left atrium gets everything on the left side gets the oxygenated, so B and D are already out. So we need to know if it comes from the lungs or the body. So it comes from the lungs. A. Any questions on that? You're going to see it again.
No, but that's a good trick.
Yeah.
Right side gets, left side gets one, right side gets something different.
Right. The largest part of the brain is the cerebrum, the brainstem, cerebellum, or the foramen magnum. Cerebrum, excuse me. I can't talk. A, I think it's A2. It's a gray matter. The three major parts of the brain are the cerebrum. We'll get into this later more. So yeah, the gray matter, sometimes called the athlete's brain. The smallest part of the brain is the brainstem. Vital function. Which of the following statement about red blood is false? They contain iron. They carry oxygen. They help fight infection. They give blood. They give color to the blood. C. Right, I would go with C. The hemoglobin molecules in red blood cells contain iron. Give color to the blood and carry oxygen. White blood cells play a role in helping body to fight infection. That's it. Anybody have any questions about carrying, moving, medical terminology? It's a lot.
It's just a lot of info to absorb.
Yeah, it is.
I have a question about the practical sessions. I think Kevin had talked about it on the first class, but I totally forgot it. What time is are the practicals in New Hampshire? Are they 8 to 4, 8 to 5?
Syllabus.
I don't see it on the syllabus. I just see it. It says like.
It says 8 to 5 on our schedule.
Where does it say that?
Hold on, I have it. If you have the.
I don't have that up. I'd have to go on my email.
Hold on. I don't know if I have it in front of me.
This one right here?
Yeah, one of them says it, but then there's
Yeah,
a place where it says 8 to 5.
It is 8 to 5.
8 to
with
5.
an hour-long lunch break. I have to account for 8 hours of in-person class time.
Right.
Yep. 8 to 5. All right. Thank you.
Any other questions? Anything you want me to go over?
Kevin,
rehash?
I got another question. I was just looking at my schedule for work. you had said that we can take a quiz from Friday to Friday. What about exams? If I had to miss an exam, would you be able to let me do it earlier or later, or what? How would that work?
Do you have a conflict with the day that the exams are on?
I think I might have one. I'm gonna try and change it, but yeah.
Just let me know, and I can open up a day early for you
All right.
if need be.
Yep. I'll let you know.
Yeah, just keep me updated. I don't want to open it up later because that's an unfair advantage to others.
Yeah, no.
But
I'd rather
definitely
take it earlier. Yeah, I understand. Yep.
So a lot to retain. Those are some of the harder chapters, but that's the basis of that's like the groundwork of what we do. Is understand the human body. Because if you don't understand that, then you're not going to understand cardiology, respiratory, and how things actually function, and the pathophysiology behind what we do for meds. Because there's EMT medications we can administer, and you have to have the understanding of how that works within the body. And that's part of getting rid of that whole technician and going into a clinician phase that I'm trying to instill in you guys. Is understand that you are clinicians in the field doing differential diagnosis from EMT to paramedic. And we're going to be administering medications that could either help or kill somebody. And I know it's a scary thing to think about, and obviously I wouldn't expect you guys to do any kind of medications right this second.